So the second bacteria which causes upper respiratory tract infection, very important, although it has reduced in incidence a lot due to immunization programs, is Corynebacterium diphtheria. So let us begin with a clinical case that will summarize the presentation of Corynebacterium diphtheria. So what is the clinical case? A 5-year-old child presented to the OPD with history of pain in the throat and difficulty in swallowing and low-grade fever for the past 2 days. On examination, his cervical nodes were enlarged and his tonsillar pillars were covered with greyish-white elevated membrane on the tonsil with well-defined edge and surrounded with a zone of inflammation. There was no prior complete immunization history. A presumptive diagnosis of diphtheria was made and the child administered penicillin and antitoxin serum. Laboratory diagnosis with Gram stain and Albert stain showed gram-positive bacilli in cuneiform arrangement and metachromatic granules respectively. So let us take out the key points in respect to this clinical scenario. We have a child which is 5 years. So a young child, 5 years of age, presenting to the OPD with history of pain, difficulty in swallowing and low-grade fever for past 2 days. Cervical nodes are found enlarged in case when we examine the patient, and tonsillar pillars were covered with greyish-white elevated membranes on the tonsil with well-defined edge and surrounded with a zone of inflammation. There was no proper complete immunization history. This is an important finding, and therefore diphtheria is a clinical diagnosis. We do not wait for laboratory confirmation. We will immediately administer antibiotics like penicillin G and antidiphtheritic serum, and laboratory diagnosis will be performed later by sending us throat swab, which can be used for both microscopy and culture. So in Gram stain, we are going to find that there are gram-positive bacilli in cuneiform or Chinese letter arrangement, and in Albert stain we find green bacilli with metachromatic granules at the end. So this is the it is a case of pharyngeal or fascial diphtheria, and we can see that there is a large thick pseudomembrane, and this pseudomembrane is responsible for the toxicity, and it may also cause obstruction to the respiratory passage, which may lead to immediate tracheostomy to save the patient. So this is pharyngeal fascial diphtheria. Now diphtheria classified on the basis of severity, it may be of 3 types: malignant or hypertoxic, and septic, malignant or hypertoxic, septic, and hemorrhagic. So malignant or hypertoxic may be adenitis, severe toxemia with marked adenitis known as bull neck, death due to circulatory failure, paralytic sequelae to those who recover. In septic cases, it will be ulceration, cellulitis, and even gangrene around the pseudomembrane. Hemorrhagic, bleeding from the edges of the membrane, epistaxis, conjunctival hemorrhage, purpura, and generalized bleeding tendencies. Now common complications. So complications may be asphyxia, difficulty in breathing, and respiratory distress. It may also lead to myocarditis, circulatory failure, post-diphtheritic paralysis, polyneuritis affecting the 9th cranial nerve, resulting in palatal palsy, toxemia, and local necrotic change. Now coming to the laboratory diagnosis. So laboratory diagnosis comes as only a confirmation of the clinical diagnosis. So clinical diagnosis, if we are suspecting diphtheria, we collect a throat swab and we send it for microscopy, and we perform a Gram stain and an Albert stain. In Gram stain we found gram-positive bacilli. In Albert stain we found, so this is an image on the left hand side of a gram-positive bacilli seen in Gram stain, and Albert stain what we find is, Albert stain we are going to find bluish metachromatic granules, also known as volutin granules, and Babe's earnest granules. So it has got a lot of name, and this is the laboratory diagnosis on the basis of microscopy. Next we move on to isolation by culture. So there are 2 culture